The next consideration for managing GDM is
Prophylactic insulin.
prophylactic insulin and metformin is no longer routinely done, case by case basis. But if after lifestyle changes, their blood sugars are still not in control, what do we do?
Add therapeutic metformin, but I have never practiced. And or insulin or increased dosage if FBS is more than 100 or 2-hour postprandial more than 120.
How many, we used to say if over 30% of the values they were taking, because we used to have women who were diagnosed with gestational diabetes test their blood sugar every day, three times a day. And if 30% or more of the values were abnormal, then we changed the plan of course. If under 30% were abnormal, then they're fine. Because some days they'll have a bad day, they ate something, they should be penalized. But if over 30%, that's a trend, over 30%, they have to take the next course of action, whether that's increased insulin or whatever. Is that what you would do too?
No.
What would you do?
I don't, we don't adhere to this criteria of 30% increase, all that.
Not 30% increase. If 30% of values were above normal range.
Because we never did blood sugar so often there.
I see.
Government
It was
hospital.
random. And you just had to kind of do a blanket because you don't know if they'd come back or not. I understand. Different patient population. Okay. And if even after we try metformin and insulin doses we're comfortable with, their sugars are too high, what do we do next?
This patient is referred to an endocrinologist if unable to control GRBS with moderate insulin dosages. Use weekly NST for fetal surveillance beginning at 36 weeks. Now, I never refer to any endocrinologist because they don't know the changes in pregnancy and
Well, they should know.
they don't know. They don't know. At least physicians there in government hospital never knew, and they would unnecessarily, even if the blood sugars were little high, they would put on insulin and all. So I never used to refer to any physician.
So
I only would manage.
you would, but some insulin gets high. No? So I'm not comfortable prescribing high doses of insulin. I'm not comfortable prescribing insulin at all.
No.
Midwives does not scope their practice, but for you, if a woman's not responding well to insulin,
We go on increasing. Titrate. And at what level we get control, we should see, and then continue that.
but aren't you nervous? If it gets too high, they're gonna have a drop. If they don't, so we're doing it based on their eating trends. And I guess here in India, people eat the same thing every day. There's not a lot of variation. In the United States, people are eating different things every day. So maybe they had something carb heavy for dinner last night. Does not mean they're going to have something carb heavy for dinner tonight. And so I get nervous with blanket high doses of insulin that would cause a lot of hypoglycemia. But here, you're right. People are eating the same thing for dinner. Roti sabji, rice sambal. Roti sabji, rice sambal. Roti sabji, rice sambal. Same. So their sugars are likely to be maintained. There's not a high risk for hypoglycemic episodes.
No.
Wow. Interesting. I didn't think about that before. How important the cultural tradition of what you eat
Yeah,
is.
they should actually eating should be uniform. Not changes should not be made so often. Uniform.
I like to eat the rainbow. Okay. So you're using weekly NST for fetal surveillance starting at 36 weeks because we're trying to prevent intrauterine fetal demise, fetal compromise, no? If her diabetes is uncontrolled or other complications arise, NST can be done by
more frequently.
Yeah.
Is not an indication for LSCS.
Diabetes is not an
Per se.
You heard this now from an Indian obstetrician. Diabetes is not an indication directly for an LSCS, no?
But macrosemia may contribute. Use ultrasound for fetal weight estimation near term. Growth scan should be observed.
What do we know about fetal weight estimation by ultrasound? It's not 100% accurate.
No, I used to do clinical only. Clinical test I used to do
What?
fetal weight.
You're touching. Yeah, that's the second best. First best is mom's perception, but they have to have had a baby before to compare it. But usually mom's perception, what we're taught, mom's perception is the first best guess. Hands-on is the second best guess. Third is ultrasound. But I've noticed a lot of doctors here won't put their hands on the belly.
They
They'll do
don't.
Doppler, they'll do ultrasound,
Only that.
but they won't touch the belly. Why?
Nowhere they touch,
I don't understand.
Even gynec cases, to do they don't get up and do PVs.
They don't do abdominal palpation?
Nothing they do.
Why? They're not taught, or they're just,
Not taught, no, they're so lazy.
they think technology is better?
Not that way. They're lazy.
Sorry.
Laziness.
But patient comes in, expects to be assessed appropriately. They're not assessed. So what can we do? Okay. Anyways, during labor, how do we manage diabetes?
Monitor for that random blood sugar and FHR during labor. Administer insulin according to JRBS status.
So we're no longer going to do their normal insulin regimen. We're dosing based on actual GRBS because in labor,
Hyperventilation.
yeah, hypoglycemia. I was gonna say something else. Oh, also having diabetes puts you in a high risk category, right? So FHS monitoring more closely, more frequently, even maybe continuous monitoring.
A continuous vital heart rate monitoring. Elective LSS for primary gravida estimated fetal weight over a certain threshold.
What's the threshold? 5,000 grams?
No, 4 kgs.
4 kg.
4,000 grams.
For diabetic moms. For non-diabetic moms, it's 4,500 based on macrosomia. In the United States, it's 4,500 for diabetic, 5,000 for non-diabetic.
Continuous infusion of 5% glucose to all gestational diabetes in labor to avoid ketosis and to provide fuel for the work involved with labor and birth. Continuous monitoring of FHR and uterine activity throughout labor. Historically, prophylactic insulin administration was occasionally used for women that are not hyperglycemic enough to reduce the incidence of macrosomia.
We no longer do that.
In our
I wanted to ask one more question. I forgot what it was. Oh, why is there a difference between estimated fetal weight for diabetic and non-diabetic moms? What happens more typically with macrosomic infants of diabetic moms? Their shoulders grow big and fat, different than a normal.
shoulder dystocia is common.
Right. Because they're more common. Not common, more common. Because their shoulders grow like rugby players, right? And so the head is fine, but the shoulders can get sticky sometimes. Whereas a non-diabetic mother, it's less likely to have fat shoulders. Right? Okay. What's effects of gestational diabetes on the fetus and newborn?
Perinatal mortality is high in patients with poorly controlled diabetes. There has been a steady decline in diabetes-related perinatal deaths in the past 25 years, from 18% to less than 5%. Major causes of fetal mortality are congenital anomalies, 6 to 13%, if GDM mothers have babies with congenital anomalies, as in versus non-diabetic incidence is 2 to 3%. This is the major cause of perinatal mortality in GDM, especially in the last 10 years. Congenital anomalies have replaced RDS as the highest mortality rate. CNS and cardiac abnormalities are common. Poor diabetic control during periconceptional and organogenesis results in CNS, cardiovascular, and kidney anomalies occurring between 3 and 6 weeks gestation. Ketonemia affects organogenesis. There is a relationship between HbA1c and anomalies. HbA1c More than 8.5%, incidence of anomalies is 3.3%.
HbA1c less than 8.5%. Incidence of anomalies is 3.3%. And when it goes over 8.5%, the incidence increases to what percent?
Sorry.
So when the HbA1c is normal, below 8.5%, the incidence of anomalies is 3.3%. In women with HbA1c greater than 8.5%, incidence of anomalies is 22%. That's crazy. That's an 8-fold increase.
Yeah. Control of diabetes well in advance of pregnancy is necessary to prevent anomalies. Intrauterine fetal death is more common in the last 4 weeks of pregnancy, more likely to happen in those patients with uncontrolled GDM. Fetal hypoglycemia because of fetal hyperinsulinemia, maternal hyperglycemia, placental insufficiency.
Are all causes of intrauterine fetal death. We have an interesting case she's just post C-section. She had a C-section yesterday afternoon. She's GDM, the controlled sugars, no diabetes prior to pregnancy, healthy and normal otherwise, normal conception. She's 39 weeks. She came in almost AFI less than 5, severe oligo. Okay, and she was having small variable B cells on NST. And so baby recovered, but it would have an acceleration and then it would dip down and then come back. Acceleration and then dip down and then come back. And so I'm thinking she has less fluid, no? Fluid provides a cushion. If the baby's large and there's less water and the baby's compressing the cord, is moving and then compressing the cord, and it's causing variable deceleration and then shifts again.
Yeah, cord compression is the main.
Right. I'm thinking we should do a C-section today, right? Don't wait. But she was counseled that we can wait 2 days to do a C-section. And in my head, I'm thinking, what if a cord accident happens between now and 2 days from now, right? There's less fluid, the baby's big, she's already having a little bit of, yeah. And so the conversation was, well, cord accidents are not very common. I've never had a cord accident. I've never really thought they were a thing. I said, well, why do you think healthy babies die at 39 weeks? Like a cord accident, right? You can't show a cord accident on autopsy, right? Because the baby's not compressing the cord when it comes out. But it can happen if the cord gets lodged between the shoulder, especially with umbilical anomalies in gestational babies, right? They don't have as much protection from those cord compression. And so they waited 1 day only and took for C-section. But it makes me nervous. If we're so nervous about intrauterine fetal demise for diabetic moms, then we should do a C-section immediately when we have concerns, not wait.
Not wait.
Right. So
I don't wait.
No, the baby was fine. Breastfeeding's fine. Everything's fine. But I was nervous.
Many deliveries, no? Here.
This week? Oh, 5 so far. Now we have 2 more in labor. Okay, anyways, I digress. So, it's not to be taken lightly. When there's more complications on top of gestational diabetes, no time waste.
Better we should.
For baby's well-being and mom's well-being, take the baby as soon as possible if complications are compounding. Okay, another complication for fetuses and newborns with diabetic moms.
Respiratory distress syndrome. Because of LS ratio not mature, macrosomia and subsequent severe birth trauma, that is hypoxia, etc. Neonatal hypoglycemia, this is very common, neonatal hypoglycemia. So we should get the blood sugar done and give glucose if there is hypo.
And lastly,
neonatal hypoglycemia.
Hypocalcemia. Hypocalcemia can cause intrauterine fetal demise as well, right? Because your body needs calcium to make your heart beat, right? The calcium channels?
Yeah.
Okay, I have one more question. So, what's the LS ratio?
That's the thin sphingomyelin ratio.
And so, why is it underdeveloped in diabetic infants?
No, there was something I had read about that.
The synthesis of some protein is altered by hypoglycemia.
Something like that. But I don't exactly remember now.
So that means that we have to be careful with diabetic moms. We can't just take everyone for C-section at 38 weeks because they're diabetic, because then we run the risk for respiratory distress syndrome.
Yeah,
So
that
we
is
have
the
to-
very
We have to keep
important complication.
right. So we have to keep both things in mind. We can't take the baby too early, but if
not
complications
too
are
late.
arising, we can't take it too late. So we have to find the sweet spot, which I think depends on provider to provider. That's why it's called the art of medicine, right? We have to do
Yeah.
some creative thinking. Okay. What does a diabetic infant look like?
Fat, obese, adipose tissue, especially cheeks, shoulders, and increased fat synthesis. No? Increased lanugo despite gestational age. Alterations in umbilical cord may be noted. Rapid drop in GRBS post birth. Suddenly the blood sugar can drop.
Right. So it's important to do close testing
And many babies die like that.
if they're not appropriately monitored.
So we have to repeat blood glucose after 6 hours and all like that.
Right.
Fetal fat placental function testing, not done for well controlled, uncomplicated GDM. NST is first line. Some providers do CST and biophysical profile. According to me, biophysical profile is very important.
It is. CST is not done very much anymore, but biophysical profile is important, especially amniotic fluid assessment.
Amniotic fluid is most important. Now the recommendation is to complete an NST and BP biophysical profile bi-weekly, correct, after 36 weeks to ensure fetal well-being. This is good. Certain risk factors will mandate well-being examinations. Persistent maternal hyperglycemia, hypertension, excessive fetal growth, and postpartum pregnancy as after 42 weeks. Long-term uncontrolled diabetes on newborn, long-term impairment for cerebral function due to ketonemia. Newborns born to diabetic mothers are at increased risk for obesity and diabetes onset at maturity. Then diabetic embryopathy, congenital anomalies still 2 to 3 times higher in diabetic fetuses despite improvement in management, accounts for 40% of diabetes-related perinatal deaths. Incidence 3 to 6% of infants with compared to 2% in general population. A 2 to 3-fold rise. Increased incidence in insulin-dependent patients. Etiology for the anomalies. Metabolic derangements in early pregnancy will cause disruption of organogenesis. Hyperglycemia can cause iatrogenic effects.
Okay. And what about the placenta?
Placenta in diabetic mothers. Placenta blood flow decreased with vascular problems secondary to type 1 insulin-dependent diabetes. Long-standing hypoxia and placental vascular abnormalities can occur. Pregnancy-induced hypertension is more frequent in diabetic mothers, resulting in injury to placenta.
We have some fun facts about diabetes. This is my favorite part, fun facts. You should start this with everything. Okay. What's some interesting tidbits to keep in mind? Okay, so one important thing to keep in mind is when you're administering betamethasone for diabetic mothers for risk of preterm birth, you have to make sure they are monitored because the betamethasone steroid can cause a hyperglycemic episode.
I never used, I
I know.
don't have this problem.
That's why you have dull babies.
No,
Okay.
intelligent. Everybody, I used to say with Dr. Hiremat, babies are intelligent, so they would come to me for delivery.
Oh, that's a good marketing technique.
They would come because the point was the children born with me were doing very better in school than others. Yeah, that was the common this thing they gave me, and I also agree because what problem is, I would monitor the pregnancy labors very well, very
You
meticulous.
have a low threshold for complications.
So look,
Nothing would be missed.
that's what. And I would post one particular postgraduate, one for each patient. I was very particular about the deliveries. I wouldn't allow any slight problem. I would get very angry.
Okay. Another is that women who are diabetic in pregnancy are more likely to develop pregnancy-related hypertensive disorder. So screen appropriately for PIH, preeclampsia, and chronic hypertension. That means appropriately taking vital signs. I know this is a basic thing, making sure your nurses or whoever's taking blood pressure is taking it appropriately, not just saying 120 by 80, 120 by 80, 120 by 80. Like actually
No, but we only used to do that.
You did that?
I never allowed sisters to
take blood pressure.
because they are very they are not at all service minded. So I never used to allow my patient.
You would take only.
And I'm surprised in a private hospital they allow.
We're on camera.
I'm surprised. I won't allow.
Okay, so what is the timing and mode of delivery for women with diabetes in pregnancy?
Uncontrolled gestational diabetes is not
Uncomplicated, not uncontrolled. Uncomplicated.
uncomplicated. Gestational diabetes is not an indication for early delivery or cesarean section. Early delivery is indicated if hypertension develops. Induction is not necessarily indicated, but if pregnancy crosses 40 weeks, it can be induction can be considered. Elective inductions starting at 40 weeks in patients with previous large gestational
gestational age
infants can improve outcomes.
All right, that's all. Is there anything you want to add about gestational diabetes?
No, I can't because I'm not having a good how to say control over my mind because since long back I've read all this. No, now I'm not prepared now, so there's no proper correlation coordination.
You have any cases that you remember that had good outcomes, bad outcomes that stuck with you in regards to diabetes?
Yes, but doctor, she delivered. There was shoulder dystocia.
She was diabetic.
She was gestational. Afterwards, she developed over diabetes, and
she
that shoulder dystocia she had. Then then in an attempt to remove the baby, there was fracture clavicle. Afterwards, the baby did well.
No brachial plexus injury?
No. That.
So shoulder dystocia can be more common in gestational diabetic moms because we talked about the fat shoulders. What are your maneuvers for shoulder dystocia? What do you do? If a mom has shoulder dystocia, how do you get the baby out?
Altering the position of the fetal head and trying to pull first to get anterior shoulder and then they lift the baby up, get the posterior shoulder.
Right. And if that doesn't work?
It has to work, otherwise what can you do?
Well, one thing I've noticed here is that doctors pull.
That's what we also do also.
But it's not evidence-based because that's how you cause brachial plexus injuries. So a midwife's perspective of shoulder dystocia, because we're taught, a lot of midwives work out of hospital, right? We don't have the equipment to do, whatever, right? And so we have to figure it out by ourselves. And so what I was taught for shoulder dystocia is shift the mom's position, get her off her back, right? Turn her to her side, maybe go hands and knees, right? Because you have time, right? It takes 10 seconds to shift the mom's position, okay? Even running the start, having a lunge position, you can try that. And sometimes baby usually comes with that because the shift in orientation of the pelvis. The other thing is suprapubic pressure. Suprapubic pressure, sometimes putting pressure on the shoulder releases that angle. And if those things don't work, then you do a manual technique maneuver where you slip your fingers under the anterior armpit and you kind of try to gently, it's all gentle, right? You gently guide the shoulder, that shoulder out, and then the other shoulder comes, right? Because you have to think about the diameters in the pelvis and what the pelvis is doing. Because if you just keep, oh, here's my baby and my, this is going to be a head dystocia. If you just keep pulling, and you're not changing anything, you're just stretching these nerves. It's not good for the baby and it's not going to potentially work. So those are the midwife tricks for shoulder dystocia.
Yeah, like that we have to try
Yeah.
such things only, because the last minute what can we do?
Nothing. You
You have to try such things.
Shift the
Position and
Yeah.
then try to make the baby come out somehow.
Yeah, somehow. Right. But fundal pressure doesn't work.
The way you're asking, I'm getting scared.
Why?
I'm feeling as if I'm on duty and I'm having a case of shoulder dystocia.
Well, here, take the baby.
But I'm scared. I'm scared of that,
Why?
because babies can die at any time.
Yeah, they can.
So that time I can't face any death, fetal death. Yeah. So I was getting scared, supposing such a thing had happened in my duty, like that.
You should be scared. Because if you feel confident,
It is the confident here. After many such deliveries, you can get confidence.
right. But midwives are taught to not practice out of fear. Because if we practice out of fear, we intervene unnecessarily. Doctors.
And midwives they don't have any medical legal problems.
That's not true.
Here
That's
there's
absolutely not true.
Here there's no
Not
medical.
yet, because midwives are not a thing yet. In the United States, midwives have plenty of medical legal advice.
That's why they have medical legal. In the United States, even doctors have medical legal problems.
Doctors have medical legal problems
Lot,
here too.
yeah.
Here.
They are less common because their paper patients are uneducated. They won't complain against a doctor so easily.
But I think the times are changing now.
Now they are
I
changed.
think people are getting more educated and the internet is spoiling
Yeah,
things. And sometimes doctors don't practice based on
they
good
were
practice.
not sometimes. They never practice.
I was trying to be kind with my words.
No, they never practice. Doctors, I will tell you, in India are horrible.
Why?
They just practice for money.
And power.
Power, no, money. So they are, that's why they are not concerned about if anything goes wrong. They should have that conscience at least, no? Humanity. They don't have that consideration. That's why I never mixed with doctors.
Who would you mix with?
Students or somebody like that. Not these established doctors. No.
I see. So I don't want to be friends with doctors.
No,
Only,
ba.
only student doctors.
Students and all. At least we can teach them, something.
Right. Well, we had a lot of nice conversations today. I think we had an in-depth conversation about gestational diabetes.
Yeah, but I'm not very happy because it was not, I didn't give a confident talk. That's all.
Okay. You want to try one more time again?
We'll try later on.
Okay.
Last we'll first finish off the topics and last we'll make changes.
Okay. Sounds good. All right. See you next time.
Bye bye. Okay, now you are